Lived and Leading Voices for Better Healthcare, where we feature persons with lived experience of a chronic condition or a disability and how they are channeling their learnings into improving healthcare. They could be providing peer support or could be advocating for changes in health systems. Patients Engage is a platform that empowers people with chronic conditions and disabilities to engage better with their health and make informed decisions. We also advocate for more meaningful involvement of people living with long-term conditions in health systems decision making. And I'm Aparna Mittal from Patients Engage, and along with my colleague, Dr. Sheetal Patel, we will be speaking today with Ms. Shalaka Parab and Dr. Prachita Shah, two young women leading pulmonary hypertension India. During the course of this conversation, we will refer to pulmonary hypertension as just PH sometimes. So, PH means pulmonary hypertension, and pulmonary hypertension India as PHI. Let's start with some background info. Pulmonary hypertension is high blood pressure in your pulmonary arteries, which carry oxygen poor blood from your heart to your lungs. And the earliest symptom typically is shortness of breath, and hence our title Breathless and bold during your typical day, not due to extra activity. And the reality today is that early diagnosis and treatment can help persons with PH enjoy a better quality of life. Now, there are multiple types of PH. So if you know somebody with PH, don't assume it's all the same. Some could be rare and others are more prevalent. And there are multiple causes of PH. They are typically defined based on the causes. They could be rheumatic heart diseases, coronary artery disease, congenital heart disease, etc. Sometimes it could just be idiopathic, which means that there is no known cause. The typical age range for PH is 30 to 60, and women are typically at a higher risk. And while PH is widely prevalent in India, care delivery for this condition has unique challenges. And today, in our conversation with Shalaka and Prachita, we will hear not just of their journey from diagnosis to advocacy, but understand the unique challenges that PH patients face from their perspective, and about the initiatives Pulmonary Hypertension India has undertaken to build an informed community of persons living with PH and to address some of the gaps in access to care, right? So let's get started because, we have two people here who have a lot to share. And this session is going to be useful for not just people living with PH, but other patient advocates as well as health system providers. So starting with both of you, right? Welcome, Shalaka and Prachita.
Thank you,
Shalaka, and
Aparna.
can you
Thank you.
start by introducing yourself? Who are you as a person beyond your diagnosis of a
Yeah,
PH?
yeah. Hi, Aparna. Hi, Sheetal. First of all, thank you for putting together this podcast around this very interesting and very important theme, which is lived and leading. And thank you for inviting us over to add to this conversation. I was born and brought up in Mumbai, and all my life I have lived with pulmonary hypertension, especially because I was born with a congenital heart defect, which caused my pulmonary hypertension. Um, Beyond what I do for Pulmonary Hypertension India with my co-founders Roshni Chaudhary and Dr. Prachita Shah, who's here, I have been working in business communications, and I have worked in fundraising for corporates. And this has helped me, it has empowered me with the tools to turn my challenges and the patient's challenges into narratives or stories that can demand attention, empathy, and change. And that is on the professional side. But in my personal life, I think I would like to describe myself as somebody who is incredibly loved as a daughter, as a friend, as a girlfriend, as an aunt, which is to say that I come from an environment of much love, support, and understanding. And it is a world of tremendous privileges. And it probably compels me to do a lot for my community to extend those privileges to them. I am also fond of the written word, and I love global literature. I love gardening, and I have a fiercely scientific view of the world.
Thank you. Thank you, Shalaka. Dr. Prachita, tell us a little bit about yourself.
Thank you, Aparna, and thank you, Sheetal, for inviting us. And I'm really liking this topic of living and leading. So, about me, I've been born in Nagpur, brought up like almost everywhere around Maharashtra and Gujarat until we settled down in Surat. And professionally, I'm a microbiologist with my special interest in infectious diseases. Personally, I'm a kind of a person who doesn't want to sit idle. So either I'll be, inviting guests, playing with family members, friends, going for picnics. I love cooking and experimenting. And if not at all, then I'll be doodling something on a piece of paper. So that's why I think I found the events which take part in PHI very interesting, especially the annual talent show which happens. And so I like doing all these stuffs. And PH has not stopped me from doing this. I have modified my ways of having fun, but it has not stopped me from who I am.
Correct. Thank you. Thank you, Chita, and welcome again. Um, Maybe Shalaka, you can give us a recap. I know you said you were born with a congenital heart defect. So if you can kind of recap your journey from there to diagnosis of pulmonary hypertension.
Yeah, yeah. So I think I've had the way I see it is I've had two diagnoses. The first time was when I was 8.5 years old, and when my congenital heart defect was first diagnosed. It was already too late, but it was diagnosed at that point, and within 3 months, I had undergone an extremely high risk open heart surgery. Thanks to my doctors who decided that, this is okay. We might be able to pull it through. At this point, shout out to the doctors at Bombay Hospital, the veterans, Dr. Eric Borges and Dr. D.S. Saxena. Um, uh, that diagnosis helped me stay alive. It saved my life. The second diagnosis happened when I was 25, 26 years old, which was a clearly pulmonary hypertension diagnosis. Again, a little too late, but it was necessary because it then uh, led to what I do for the rest of my life. It changed my life. The first one saved me. The second one changed my life forever. And between both these diagnoses, I was asked to lead a normal life. I was not asked to monitor symptoms. And this is unfortunately the case with children who from the 70s, 80s, 90s who've survived congenital heart disease. And so a lot of symptoms went dismissed or undiagnosed or ignored. Um, and so I ended up doing all the things that anybody at my age should have done, but also that it may have progressed my disease beyond a certain there's no coming back from it point.
Right.
So it's two diagnoses for me, and yeah.
Thank you. Thank you. Prachita?
Yeah, so I did not have any symptoms until I was like working full time in Mumbai, which also included 2 hours of travel time. And it started with a dry cough. It's a very common symptom of cough. So I didn't I dismissed it for a while and then self-medicated myself. Then it didn't improve. So I started further investigating and I did blood tests and so which showed anemia and with B12 deficiency. And I confirmed it with the doctor uh, close by, and he told me to take B12 shots. And that did not improve my condition. The breathless worsened. And so I took like, okay, this is because of all the fatigue of working and doing chores at home as well. So let's take a break. And I took a break for around a week or so. And it still didn't improve. Then I went to another doctor and where echocardiography was done and it was found that it is pulmonary hypertension. So that came to me as a shock. But after finding out that it is PH, I wanted to know what has caused it. Since childhood, I've been a very active child, playing games and everything. So why has it happened? And I went to multiple doctors all around India. I went to Delhi, I went to Chennai. I've gone everywhere which has a specialist in maybe rheumatology, cardiology, anywhere, and still didn't find the cause. But in that period, I realized that I have not been focusing on the management part. I
Mm.
am focusing on cause part, which is not right. Okay. And and the struggle to find the cause was real. Now, retrospectively, when I'm telling you all this, it looks like simple. Okay, you took this, you went to this doctor, but it took almost an year to reach to that diagnosis of even PH, and which is the real struggle which everybody faces, and with no visibility on Google for any Indian patient. Like there was, if I could search, there was no PH specialist, there was no PHI, and so finding it, finding the resources is so important. And
Right.
it is also important to understand that many PH patients do not have cause. Okay, so
Hmm.
don't go after the cause. It will continue. Like recently, I had the genetic test done to find if there's any mutation,
Hmm.
but no, that is also negative. So it's okay. But focus more on the management and lifestyle part of it rather
Right.
than cause.
Right.
Yeah.
Thanks. Thanks,
Aparna,
Prachita.
can I add one small thing here?
Yeah.
For
I
for
actually also wanted you to add, I think what we didn't touch in yours was your symptoms that got to your
yeah,
second diagnosis. So if you can also
it
touch on
was
that so
it
that,
was the same thing. A lot of breathlessness, struggling with slopes and stairs, or even walking beyond a point. And I remember spending all my pocket money back in college on auto rickshaws and cabs. And my mom would insist that no, you should go by bus. And I would save it all up to go by an auto. The point I wanted to make with Prachita's case, and also in some way mine, that it took 15 years for my second diagnosis to happen. And that is, it's not because I never went to a doctor. I kept
Hmm.
going to doctors with different symptoms, but nobody uh, thought that a CHT patient, a known CHT case, should be monitored
Not.
for heart
Yeah.
anomalies. And right before my diagnosis, 1 year before, I was also on B12 supplements. The point
Hmm.
I'm making is young women with heart disease are so often dismissed for vitamin deficiencies, or um, also, seeking
Hmm.
attention, or, oh, it's nothing. It's, maybe you just need to eat well, which is true. You also need to eat well. Nutrition is a big problem with young women.
Right.
But it is also that I also went to multiple doctors for various other things. Could have also been diagnosed, but I did not get
Hmm.
diagnosed.
Hmm. And in your case, it's in a way even more, right? Because you did have a specific cause,
Yeah,
which
yeah,
every doctor would have known about.
yeah.
And so has that changed in terms of awareness that a child with CHD has a greater risk of PH?
Yes, because of
Yeah.
what's being put out by the global organizations working on CHD, and also some in India. And also us, we also put out a lot of content on CHD of how important it is to monitor. If your child is surviving into adulthood, or even if your child has gone through critical surgeries at the age of
Hmm.
6 months, 1 year, 3 years, they still have to be monitored. We tell parents, do not be complacent about this. It's
Hmm.
okay, spend that money, go to a good echo center and get your child through a proper 2D echo, and go meet the cardiologist. Even if the cardiologist is not expecting you to come, go meet them.
Hmm.
Let them scold you, let them scold the parents, but let them go through one echo report and find out what's happening. Because a lot of these CHDs are ending up with pulmonary hypertension,
Hmm.
which when treated at the right time, will lead to a longer life for the patient. The more you delay it, the worse it gets. And I'm one
Right.
of the very, very few rare cases in CHD who has, lived so long. Of course, mine has also been close, so I do have that advantage. But generally, with a late diagnosis and a
Hmm.
late surgery, it's not easy. I've lost a lot of CHD friends in the community.
Right.
So
Right. Right. Thanks. Um, and so tell us what led to setting up PHI. What was the idea behind it? What was the objective when you first started?
See, we actually started at the heart of COVID. This was in April, May of 2020. And we were approached by Dr. Prashant Bobati, who's one of the foremost PH specialists in the country at Kokilaben Hospital. He was like, World PhD is coming up on 5th May. What do we do? Should we, do something? What was it, Prachita? Living with PH webinar.
Living
Uh,
with PH. Yeah.
yeah,
So
living
how to
with PH
stop
webinar.
worrying and start
Yes.
living.
Yes. And at that point in time, we were already a nice little cozy WhatsApp group, which was started by some other patients and which I and a few others had helped build over many years. But this was a first opportunity or an offer to actually have a public face to who we are. And I think at that point in time, my business comms thing kicked in. It's like, okay, if we are going to face the public now, we have to, organize ourselves, formalize ourselves, have a brand in place. And that's how we just put a name together. And the first thing we did, because Roshni was part of her team, and she was already a very successful blogger and a beauty and fashion blogger and influencer. So she had figured out the social media space. Like, yes, okay, Rosh, let's work with Roshni on doing this. And she happily um, helped set up everything, and that's how we started. I mean, I think the main goal was obviously the webinar, which was a more tactical short-term goal, but also it was like, okay, we have already learned the value of building our community. At that point in time, I remember before COVID, I used to actually go and find PH patients all over the internet. I used to write emails to doctors, do you have a PH patient? I used to go on different social media platforms. In different languages, I would use keyword searches and reach out to people. And also because people were not necessarily coming out and saying that they have pulmonary hypertension, but we had to look for little clues here and there and say, hey, is it this? And then build the community that way. But yeah, I mean, that is how we started. And it's been 5 years now. Yeah, it's been 5 years. And we realized very soon enough that, only the collective voice matters. It's either the collective voice or no voice at all.
Right,
Yeah.
right. Thank you. And Prachita, what drew you to becoming an advocate? At what point after your diagnosis you felt, okay, I want to do more than just managing my own condition?
Yeah, so here I would like to first highlight how I came to know Shalaka. So the credit all goes to my brother and my husband. My brother stays in US, so he found out about the Pulmonary Hypertension Association, which is a global thing. And from where in India chapter, there was name of Shalaka and an email address. That's how we contacted him. And similarly, my husband found out about Prashant Bobati, the only PH specialist at that time, and we contacted him, and he also, guided us to Shalaka, that she is having a support group. Meet her, and you will know what it is, what is important and not. And being from a healthcare background, I can say that support group, the community, it is very important. With healthcare system, it's only like, okay, take medicines, be better, all good, okay, we'll see you on next follow-up. But no, there has to be a continuous communication, and the care and empathy which Shalaka and other volunteers of that time provided, it was very, very good and very calling, appealing to me. I started with small events, volunteering for small events. But then I started seeing how impactful they are, how many lives we are touching at a time. And so I asked Shalaka, and she was like more than welcome to have, as many people with her joining and volunteering. And I think that's how I added.
Nice. It's always good when there are more people contributing, right? That's the power of patient communities.
Yeah.
So Shalaka, what from your perspective now, you started as, okay, let's do this webinar, or you started as, okay, let's try and build a community, but what are the top three priorities? And I know you may have multiple, but let's focus on the top three that PHI is focused on for the next few years.
I think even though there are multiple priorities, they can be easily categorized into three sections. First and foremost is life extension. We need to first save the life of the patient. So if it means creating access to expensive medicines, creating access to advanced medicines, PH specialists in the country, or help the patients make the right decisions. All of these go into saving the patient. That is the first and foremost thing. Second is, of course, now that the patient is alive, how can we improve their quality of life? And so everything that falls under that category, which is basically access to mental health resources, nutrition, physiotherapy, career counseling, sex and relationships, insurance, all of these things, they are adding to your quality of life. I think Prachita helps a lot in that front. Those are the things she mostly leads. And then there's the third, a very important one is policy advocacy for all things that matter in the first two categories, right? So whether it is now we are working on the rare disease listing, we also want to work on the disability listing. There's also some input in the curation of international and national level treatment guidelines that will impact our community in a big way. There's also a more organized approach to PH and heart failure treatment in India through all of these things. So it's that save lives, quality of life, and policy advocacy.
Right. Thanks. And I think Prachita is a doctor, right? You probably kind of react. I know Shalaka is also extremely evidence-based and science-based, but what has been your experience as, the myths you've come across and what you want to address using this platform today?
So there are actually a few common myths which I would like to discuss here. The first is people go on the Google and they see short lifespan. Means okay, they do not read the details, but they just from cursory reading they find okay, it's a short lifespan. But no, so I want to clarify, pulmonary hypertension is not short lifespan if you are taking proper medication, following the lifestyle changes. We have seen patients going for decades. Okay, so it's not just 2 to 5 years, it's decades. So have patients, follow guidelines, like follow our support group, find good doctors. Yeah, and the second myth is like it can be curable. No, PH cannot be cured. It will be maintained, and with good medicines, the worsening of symptoms can be prevented for a longer time. But with medication, with treatment, you have to understand that there is a very normal feeling which comes immediately after the management. So immediately after you start taking the medicines, these drugs are so good that you start feeling normal. The pressures also show improvement, and you feel that, oh, the disease has gone now. Some even stop medicines. So no, we have to be very careful during this stage, this sweet spot. It has to be tended with care, otherwise you will end up worsened very fast. The last myth, I would say that natural, many in India still prefer natural pathies or natural treatments. They try to reduce the pressures naturally by using so many, I don't know, quack methods. But what I would like to say is that only evidence-based, globally approved, FDA-approved medications should be used. They will only help you in the long run.
Right. So, coming back to a couple, just to clarify, right? You said that one is that, you get to a sweet spot. And so in your experience, you've seen people kind of stop their medication that time, or what happens? And how do you then counsel them as to why it's important to continue?
So we counsel them, giving examples. That's the best way to approach, because obviously people learn from others' experiences. And after showing them, like for my personal example also, if I can say, my pressures also dropped. And being the carefree person I went for a badminton match. It was just like a neighborhood match, but then it worsened me for a bit. And that's how, like, I was okay, now alert, okay, this cannot be done. I have to be very sure, and I have to take baby steps with this. uh, Lifestyle modifications is a much needed step. You cannot be your original previous very active self.
Right,
Yeah.
I would say beyond lifestyle, life modification is very important. You have to change your life. You have to rethink your career. You have to rethink your marriage if you're married, or your relationships, or what kind of a person you're looking for. You have to rethink a lot. And that sweet spot, when it happens, people lose that sense of urgency
right.
to take care of their health, and they end up making the wrong decisions when they should be always still making that conservative decision, so that you can have a much longer life in the eventually.
Right. And in terms of, you also talked of the use of alternative medications, etc. Again, in your experience, have you kind of figured what, um, is it the cost of treatment that drives those decisions, or is there a hope for a cure in those treatments that drives the decisions? What has been the kind of more common uh, thread?
So it varies actually. I think like uh, it varies from region to regions. In rural areas, it's mostly a socio-culturally driven decision. Okay,
Mm,
because they all the people around them, they are saying, oh, this doctor is very good, he will cure you in no time. And in a more educated society, it's like too much research sometimes. People are
mm,
more afraid of side effects rather than the advantages of the medicines which are keeping them floating.
mm.
So that is the diversity which we see.
Let's see.
And none
Okay.
of these alternative medicines are cheap.
Mm,
We have had patients spend 40,000 rupees a month happily on those while they are, underdosing or undertreating themselves on the evidence-based medicines. So it's not
right.
about, at least in the urban centers, we see that that is not the case. Like Prachita said, rural, yes, definitely, it's the social-cultural thing. And,
Right.
and and the fact that it is not curable, it's very difficult
Mm,
for patients and families to accept that it is not curable. How
mm.
dare it be not curable? I will find a way,
Fine. Mm,
right?
right. So, over the last, whatever, 5 years, as you've said, you've built a fairly dynamic community. It's an active community. It's probably, maybe you can talk a little bit about how the community has grown and what were some of the, you know, methods you've used to grow the community.
Yeah. So this has not been by design, but today we happen to be India's second largest cardiology patient community, and maybe the second one in the pulmonology side as well, Lung Connect being the first.
Mm,
Um, for somebody who's so niche in cardiology and pulmonology, we've really gone quite far ahead. And we are as surprised as everybody else is with what has happened. That said, it is now a position of not just power, but also responsibility. Because we do have those voices and the platforms, and so we have to use them very carefully and use them for the right objectives. We started as digital first, obviously because it was COVID, but also because of the nature of a disease. It's very difficult for most of us to step out and go for a community meeting, even if it's in the neighborhood. Most
mm,
of us are not open to doing that because it's an exhaustive thing for us to do. And the demographic that we are serving is also digital first. They're digital natives, at least the young ones, in
mm,
the teenagers and the 20s and 30s. They're digital natives, so it helped to be digital first. And start creating our assets and all the knowledge and awareness campaigns that we started doing at that point in time. It is purely out of luck that Roshni has been by our side, and I don't mean to say that it's good that she also lives with pulmonary hypertension, but no, she's been a great asset and critical to starting this with us, for all of us, and then taking it to a level that is now compelling enough for all the stakeholders to notice,
mm,
and for us to get a seat at the table. That is what has happened. What we did was, the very first thing we did was we went on Instagram, because that's where all the youngsters were, and
right.
even today in India, that's where the youngsters are. The second thing we did was we went on Twitter. That's where the global conversations on pulmonary hypertension were happening. And so we had to put ourselves into those conversations. We had to,
Mm,
slowly slip into, hey, we are also here, we are in India, and, we also have all these patients, and we have all these medicines, which none of the other developing countries have, purely because of the generics revolution here in India. And slowly and gradually, they started noticing us. They started talking to us. They would DM us, and even now they do DM us with offers for support. What can we do for you? Would you like to be part of the study? I want the Indian perspective. Recently, last year, the World PH Symposium happened, where they curated global guidelines. They updated the guidelines on pulmonary hypertension. treatment protocols. And they invited us to, offer the India South Asia perspective. And this had never happened before, but it happened because we said, hi, we are here.
Right.
We had to go, introduce ourselves. Then we went to Facebook because that is where a certain middle-aged um, uh, uh, Indian patient is accessing the larger FE groups, and also probably, doing it, sharing things with their families. Very rare, not much, but they do access the FP groups. And finally, now we have only very recently started curating for LinkedIn, which we probably should have done it much earlier, but only now we've done it. And this is where we are now connecting with the larger healthcare stakeholders in India. And also maybe globally, yes. I mean, that is a more formal setting. Twitter helped us, have instant organic conversations with those who matter.
Yeah.
And also get
And
a
the
follow
nature
from
of
them.
Twitter's changed in the last
Exactly. Yes, that has
so-
also happened. Yes,
Yeah.
yes. But it was quite useful to what we wanted to do, because today anybody who matters in the PH space, whether it's a scientist or a doctor or a pharmaceutical executive, they follow us on Twitter. And that makes a lot of difference. So if we really quickly need something, sometimes all it takes is a DM on Twitter or LinkedIn, and that's it.
Right. Right.
Right. In fact, our website took a long time. It took us 4 years to launch our website. We were like, okay, yes, we'll get there. But because Google was, anyway showing us up on, like, you do a keyword search for pulmonary hypertension and India, and then we would show up everywhere. And that's how patients would start, finding us, discovering us, and joining our community. And then there's the other process of building the community, which is so much about a little bit of gatekeeping also, because we have to evaluate them for what type of PH they have, whether they have PH or not. We get a lot of queries about not queries, but oh, I think I have PH because I saw what the symptoms, I read about the symptoms, it says that I have PH, or the wrong diagnosis. The papers say PH, but probably that patient does not have PH. So we have to then send them to the PH specialist to, get a echo done again, or to be evaluated again, and they come back with no PH. And and then we have to verify whether they are truly a patient or a caregiver, because then you have vendors wanting to enter the community, pharma executives, and we are very, very strict about that. We gatekeep. Yes, it is essential. We gatekeep, and so we are very sanctimonious about who we include into the community. Yeah.
And do you moderate the discussions in these communities as well?
Absolutely. We have very thoroughly thought of and curated guidelines for the community. And it's like being a class monitor 24/7.
Yeah, the conversations have to be around, in and around pH only. The
Yeah.
side effects, the medicines, everything. Anything other than that, like, it's rejected. Yeah.
Even pseudoscience is not entertained beyond a point.
Right.
A little supplementary something to, manage symptoms, okay. But oh no, this is a doctor who says he or she is going to cure it with these fancy herbs. No, delete.
Right.
Uh,
Right.
it's a constant, it's a 24/7 job, very honestly. Monitoring and managing communities like that. But it's okay. I mean, I think we are also evolving. We've learned a lot, and but we refuse to back down on our standards for what the standards we want to maintain in managing communities.
Right. Right. Um, and if somebody needs to reach out to PH, is the only way through your social media handles, or is there
Not
any
at
other
all,
way for
not at
them?
all. Although we do get a lot of DMs on Instagram and Facebook, people reaching out, but we get a lot of references from doctors now. From only Dr. Bobate recommending us to now everybody who works in the PH space in India recommends us. And so the patients are sent to us, they are given our number, or they go see our website. We also have a patient community entry form that they have to fill up. And that's how we connect. But at the same time, all the evaluation process has to be thorough, and it takes a few days, in fact, a few weeks sometimes. But that is how,
Right.
references.
So, I think we've come across this, right? Women are at higher risk of PH, Prachita. And is that also what you see in your community composition? And also as a PAG as a patient advocacy group? How does it affect? What are the issues you're trying to address as a community?
Yeah, so like in our group, if I look amongst all our members, 75% of them are women.
Mm,
And if you read about the global statistics, then you will find that the ratio of men to women being diagnosed with PH will be 1:4. So that's how
mm,
this disease is more prevalent in women. And that's why, by design, I think PHI is started by Shalaka, Roshni, and with me later joining them. And this organization, it focuses like more on women. We being women, we can connect with them, um, and the bonds are like across country, across caste, across class as well.
mm,
And we understand the like what is at stake. It is the physical, mental, social, and even financial issues. So
right.
um, we have to be very careful about what we do in this organization. And plus also it's important because the doctors, the pharma companies, they all are very dense with the male perspective. So we have to redirect them and redefine some of their goals so that they serve our needs. And because the medicines or these things have to be made with women be kept in mind. And the stress or like a typical woman who lives with PH suffers so much. Like it starts with menstruation, anemia, contraception, contraindication of pregnancy, absolute contraindication, or worse if the patient develops PH after delivery of child. So these young mothers, they cannot even pick up their child. There's also risk of early death. So just imagine, the child being motherless at such a young age. Mm, Other than that, the women also face disabled dating. Uh, like it's very difficult to find partners who support you.
Mm, mm,
Uh, so we have seen so many heartbreaks. There's breakups, there's divorces, abandonment,
mm,
and where do these female go? If they go back to their family, they become financial burden for them. And with being physically incapable, they're not able to productively uh, contribute to the household as well. So
right.
the guilt, they are so much guilt ridden. And that's why it's very important that we as the admins, we develop this PH sisterhood amongst ourselves who try to help each other, through these issues. We counsel the patients, even the families. We have to make sure that they don't feel lonely or unheard. Okay. And we also provide career counseling and support female entrepreneurship because they
Mm.
start small businesses. We have many fighters who run small businesses, and we are proud of them.
So just for the audience to know, when you say fighters, you mean PHiters,
Yes.
right? So
Yeah.
Yes, yes, yes. The PHIGHTER is a fighter. And so sorry, we it's common parlance for us, but yeah,
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 yeah.
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 So you said something in the beginning that even from the healthcare provider and the doctor perspective, it's a very male-driven uh, perspective. Um, can you give an example of how it affects the way a woman patient is, treated, or what you've done to make a change in that?
So a very simple and common example is in menstruation. If you see, like, it is affected and there is irregular menstruation for like many females, female PH patients I've seen. And when we go with this complaint to our doctors, it's like it's not severe. You just don't worry about it. It is there
Mm,
now. You are not feeling anything bad now. Okay, let it leave, let it
mm,
go. Don't
mm,
worry about it. Your main health is you don't feel breathless. Okay, then
mm,
it's fine.
mm.
So such symptoms which are important for us, but they get dismissed. And anything you would like to add, Shalaka?
Um, I think it's also when a young female patient is diagnosed, the doctor will obviously talk about the contraindications for pregnancy. Uh, But beyond that, and this is, I think, where the community comes into play, is it's just not okay to just say, don't be pregnant, don't get pregnant.
Mm.
There's so many decisions that are around that one little, not little, one big factor.
Decision, yeah.
Yeah, one big decision. And so I think nobody in the healthcare system understands this point. Not, I mean, the administration, obviously, but also this point that, there are so many other things. And that is where the conversations between women, us women, matter so much, because then we talk about, okay, what kind of a person do you want to marry, or do you want to marry or not?
Mm.
Right, first of all, then, depending on your socioeconomic background, are you allowed to date?
Mm.
Are you allowed to have this open conversation with the person who you are arranged married, I mean, there's arranged marriage happening? What about the finances? Is that person going to support you if you're not able to go to work every day and generate the income to support the medications at least? So there are
Right.
lots that, and of course, no pregnancy, then what?
Mm. Mm.
Does a surrogacy or a IVF also make any sense? If you have the money, everything makes sense for you.
Mm.
But if you're a middle class person with, probably living in an urban center without a joint family, it does not make sense. One, you don't
Mm.
have the money to, go through the whole
Go
thing,
through those
because not,
cycles.
yeah, you will also need not just for the IVF, but also you need money for a very comprehensive big team of cardiologists, pulmonologists,
And
anesthetists.
the pregnancy itself will
The
be a high
pregnancy,
risk
yeah, it's so
event,
high
right?
risk, and
Especially if it's
yeah.
IVF, it's even more high risk. So,
Yeah, and then what happens? Okay, there are scientific papers out there saying we had a successful pregnancy case study, and then breaking news on uh, uh, these research sites. But what after that? Have you found out how the woman is doing? The mother is doing? Do you know how fast the pH is progressing after that delivery? Even if it's a C-sec,
mm.
it's horrible.
And
The
how many women did you need to go through to get to that one successful pregnancy, right?
exactly,
So,
yes,
that's
absolutely.
Exactly.
that's
So
as
I
as
actually,
in research they call number needed to treat, right?
yeah,
So,
yeah.
what is that number?
Yeah, and it's I mean, it's looked at so objectively when it should not be, because it's such a large, very complex subject. You have to look at it beyond the clinical side of it. Just saying that, we will ensure she has a successful delivery and goes back home after 10 days, 25 days, whatever. No, what happens after that?
Mm.
The family does not have the money left to even spend on her medications. And
Mm.
then, if there is an early death, what happens to that child? Or sometimes there are adoptions. Adoptions also are complex. We have, yes, everybody should do what they need to do, but they are also complex. You need to lie if you're going to adopt.
Mm.
Nobody's talking about that. Is it in the interest of the child?
Mm.
And then again, early death of the mother. So if the father remarries, what happens to that adopted child?
Mm. Okay. So and this is to both of you, right? Because you both mentioned the fact that one of the key objectives you have is life extension, but it is, especially in a country like ours where diagnosis itself is late and access to, uh, treatment, kind of good medicines is also limited. Um, and essentially, you are a community of people living with a life-threatening or a critical illness. So, how do you handle the depressing mortality rate? And both as co-founders, and how do you support the community in terms of handling this?
You want to start, Prachita? It's not my favorite topic at all.
Neither mine, but
No, and I know it's not an
I,
easy topic, but I think often patient groups struggle with this, so it's important that we talk about it, right? This is also the burden in a way of
Yeah,
the invisible burden of running a community, which
yeah,
nobody talks of
yeah,
as well. So
yeah,
yeah, go ahead.
so
Sorry.
the regarding community, one point I can add is that all of us are growing with the community. It's not at all easy to talk, like, express grief.
Mm.
It was not, like, for me personally also, I go silent. I'll go in a shutdown mode, hibernation. But these frank conversations in the group, which we have had recently. It has, I have also matured in some way. I've started speaking about my emotions, about understanding what is happening in others' life, how the family members are coping. So it's very important that we keep these channels open, keep these conversations happening, time and again. And for me, I keep those fond memories with me every time, and you know remember them. There's so many small things which happen to us in day-to-day life, and we, oh yeah, if she would have been here, it would have been like this. So uh, yeah, that's all. I don't think I can talk more about it.
Yeah, so
Yeah.
sorry for triggering, some of these.
No, that's
Shalaka, you want to add anything?
yeah. So I think as a community, the first thing we did was also normalize these very difficult conversations and
Mm,
normalize the discussion on death. First, normalize the discussion on acceptance
mm,
of a chronic progressive illness, and then the conversation on death. Over the last couple of years, we've shifted our focus to advanced care planning and palliative care. It's extremely difficult to get patients and the families to take it seriously, but we are making small headways here and there. Um, we've used humor to speak about death. We've had, like Prachita mentioned, just a few months ago, we had too many, one too many deaths happening one after the other, and we had a nice conversation within our community about, okay, let's talk about what it means. What do we do? How can we prepare ourselves? Um, what is what is coming our way, no matter what, no matter
mm,
all the disease management, all the best decisions we make, choices we make, it is still coming. It is definitely easier to accept this as a community than it is to do it as an individual.
mm,
So I am myself very thankful for this community because, yes, I have myself evolved through this particular difficult subject. That said, the losing people in the community is very, very difficult because, at least the way I am, I end up creating bonds with individuals. They become friends. They become very dear friends. It's an everyday conversation of, hey, what's happening? This is happening. Symptoms, or I don't feel like doing this, or relationship thing, or just laughing at ourselves. And so when we lose those patients, I definitely, I think for a few days I'm not myself, and I try to. I think I'm forced to withdraw from some of the work that I do.
mm,
At one point, my doctor recommended grief counseling for me, and I've still not taken up on that, but I should, because this is very important. And I think it's one of those things that I think I should do, and probably as co-founders and leaders, whoever else is also there, are many other patient leaders in our system. We should all be trained to manage this better.
mm.
If there is any kind of formal training for patient advocates to deal with death,
Right,
uh, and the trauma that comes from it, I think we would want to take it up very seriously and urgently.
right, right.
One of the doctors recently asked me, Shalaka, it must be so delightful to have to be building this community. I was like, what are you talking about? This is so
Delightful.
delightful that you have such a beautiful community. It's like, no, it's most of it is trauma.
Yeah.
I laugh through the trauma, but it is trauma.
It is trauma. It is
Yeah.
trauma.
Yeah. And sorry, I must mention this. We used to post about the friends that we lost, condolence posts on our social media, because the families would want that. The
Hmm.
families would love it when we would post about the loved one passing. But it had a very mixed response, and we had parents and caregivers and sometimes patients who would resist coming to the platform. Then it's like, no, it's too negative. We will unfollow you. I don't want to be in the community. Um, I can let it be. I can let it be, like, to each his own. But at the same time, I also have to take that into consideration, um, as to how something staying on your platform, and when somebody is going through your past post looking for information, and then they come across
They
this
come
thing,
across.
especially
Right.
young people, with condolences, being passed on from everyone. It's
Hmm.
difficult. So now we've decided to not post them anymore. We've archived the ones we already had. We now post only those where, somebody has made a tremendous contribution to the community, or in some way or the other to healthcare and for patients, and we leave it at that. But there's definite, I do not like not acknowledging my friends who've
Mm,
passed.
mm,
It just doesn't sit right with me. I cannot
right.
not say something. And so I will do my thing, in my own way, maybe not as a PHI platform in my own way as Shalaka, but at the same time, like you said, patient organizations struggle with this concept. There's no right way. There's no uh,
Yeah. Yeah.
guideline to doing it right without messy emotions here.
Yeah. Yeah. And um, as you reflect over this journey, right? What do you see? I mean, you've obviously built a very strong and dynamic community. It is, as you said, a niche diagnosis. Uh, but what have been the challenges, and would you be willing to share some of the mistakes
Yeah,
that you made?
happily. Happily, because it's important that we acknowledge our own mistakes and challenges, and also somebody else learns from us and doesn't end up doing the same thing. I think um, building a patient community in a niche space like this, where nobody else has done something like this before, is just like building a startup.
Mm,
Everything is trial and error. Neither of us have had any training in being patient advocates or being patient leaders, right? So one of the earliest mistakes we made and realized soon enough was that not everyone wants to speak up.
mm,
So we made the social media platforms, we created the handles, we created the content, but now we're inviting patients to talk about the stories. Aparna, it is so difficult to get patients to talk about the stories.
yep.
Yeah, they don't want to, not everybody is interested. Very few want to speak up, and there is a reason. They don't want to share the story publicly. It's because it's the pulmonary hypertension is an invisible illness, and sometimes they want to allow it to be continue
To be
to
invisible.
to be invisible. We have we have found it the we have realized this the hard way, but sometimes now advocacy is not necessarily visibility. Sometimes
Mm,
you have to respect the silent forms of strength as well. And so maybe we engage and involve those members of the community in a different way.
mm,
I must have missed saying this, but community building is not just me, Roshni, Prachita. Every single person who comes to us and says that I can do something for my community now, because it is their community also, we involve and engage them in whatever way that we can. So
right.
it's not that they can be involved only when they speak up. They
Mm,
can be involved in, Rahul builds the website, Nitya helps with something else, Hema helps with creating videos, Vidisha helps with doing the medical aspect of things. So many, Balaji does memes, Ganesh does something else, every single person. So it's, as I think as co-founders, it's our job to, get everybody involved in the best way possible using their talents and their skills. But coming back to the invisibility part, um, if the illness continues to be invisible, then there's nothing much we can do beyond it, because it distracts the stakeholders from talking, from taking us more seriously. It breeds delusions and denials, and it affects the larger conversations for that need to happen around disability rights, around patient rights, or around acceptance of young people with cardiopulmonary medical conditions. So it makes it very difficult for us. That is one. Secondly, I think the biggest challenge has been the heterogeneity of India. India is
mm,
20, 25 different countries, right? Yes. I do not have the resources to reach out authentically and most empathetically to these multiple Indias within India. So we continue making mistakes in our communication, in our strategies, and it's something we constantly correct on and build for. And the mistake that I think we continue doing is that we are not pacing ourselves as patient leaders. We are not pacing ourselves, and we deal with a lot of leadership burnout.
mm, mm,
The leadership burnout is a huge problem. The knowledge that we have is within the minds and hands of a few, and they are burdened. They are
mm,
overtly burdened. Just recently asked around in the community if there are any AI tools that we can start incorporating to use all the knowledge that we have here, the data, the knowledge, the numbers, and if they can start doing at least Q&A with the patients for basic things.
mm, mm.
So we are looking into building that now,
Right.
so
Right.
that as human beings we are also, and we are patients
Correct.
first.
Correct. Okay.
we need to be unburdened a little bit.
Mm. Mm.
Something that technology can just, help in um, coping for us. So
Right.
yes, patient leaders need to take care of themselves first
Mm.
before they learn to take care of other people.
Right. And I think you made another
Uh,
interesting point. Sorry, Prachita, you wanted to say something?
yeah, I wanted to like just give an example. It was recently we had a webinar with the cardiologists and all the esteemed doctors in Mumbai, and Shalaka was supposed to do uh, the slides for PHI, introducing them, introducing us to the community. And the day before, we had a private meeting with all the PHers who lived nearby. And but these 2 days, they were so hectic. She did more than me. She came early in the morning and went, like, stayed till evening and got up early and came for the next day also. Like, this is physical exhaustion to the maximum. Like, no PH patient can tolerate so much, but being a leader, she had to show up, she had to do that. And this is the burnout which we are speaking. This is just a glimpse of what actually happens. So I just wanted to highlight it.
Yeah, and I think that is something which we need to figure out how to change, right? I mean, while obviously advocacy requires visibility of invisibleness as well, but there has to be other ways of acknowledging, um, you know, the strength of people's illnesses without having them to necessarily be out there to tell their stories, right? So it's a little bit of a dilemma, but I think there needs to, and that's a broader conversation. It's not PH related, but I think,
Yeah.
this expectation that advocacy requires people to speak up about their narrative is a little, in my view, last decade
Yeah.
almost. So we need to kind of work towards that as well. Um, because that also brings with it the challenge that, especially in a country which is as heterogeneous as us, and with so much health equity issues and social equity issues, how will you ever speak on behalf of so many others if you keep expecting people to be every community to be able to represent themselves, right? So there has to be a different model to it as well.
Yeah.
um, so coming to and Sheetal, I think we'll need you to share your slides here. Um, you know, Prachita, obviously you all have had some challenges. Some things have worked. Actually, most things have worked. A few things haven't worked. What, in your view, are the factors that contributed to your success as a patient advocacy group? And also asking, I know, you know, you wanted to share some of these slides, so we've got them as well.
Yeah, so first and foremost, it's a shout out to family members like me, Shalaka, Roshni, and me. All of us have such loving and caring family members, which they give us all the strength and stability so that we can go out, build, and serve the community of fighters. So without them, we couldn't have, even thought of doing such things. So first and foremost, it's like we're really grateful to have such family members who are always there with us. And regarding this organization, I would like to highlight a few points. The first is like
So
it's a unique.
do you want Sheetal to not share the screen yet?
Yeah, actually, towards the end, maybe
Sure, sure.
I can say I can hint it.
Yeah, yeah. Okay, go ahead.
Yeah, so PHI as an organization is unique in the sense that it is an emotionally authentic community. The way we connect with people, it's always personal, it's an honest conversation. And so the trust building and being emotionally resonant with them because we ourselves being patients, that is the rare support which you cannot find with other healthcare institutions.
Right.
And and our approach has always been community first, and that's why we have seen that so many patients and caregivers, they stand by us, they support us with their time, money, and efforts. And other thing which I can highlight is the strategic impact. So it balances, like we are doing local awareness in the India, South Asian regions, and we are connecting globally also. So the gap between awareness of pH around globe, that has reduced. And the content, like the digital media which Shalaka had told earlier, so the webinars or the events, whatever we do it based on the feedbacks we receive from patients. And also we do it in such a way that it is clear and accessible uh,
Mm.
type of communication. And as discussed, the support groups where the communications happen, which is private for patients, the rules are strict. We tend to be ethically strong there, and we do not want to misguide anybody in that space.
Right.
Also, another important factor is the collaboration. We collaborate with healthcare givers, we collaborate with pharma companies, and but it is a non-territorial spirit. We do not want to, say that we are attached to one particular thing. No, we want to do collaborations for the benefit of PH patients always.
Mm.
And yeah, coming to the slides, so this is the most important part which helps us deal with all the severity and seriousness going
Sheetal,
in
you
our
can share
journey
now.
of a disease. Yeah, this is where we, so these are the memes which convey important points along with humor. So it's basically a sense where we get to emotionally release and take a mental break. And Shalaka and Balaji are the two important people who create these memes for us.
Balaji is a fellow PHR from
Uh,
Bangalore. Yeah.
yeah. So the first, as you can see, which was the common myth I told you about. So
Hmm.
whenever the PH patient joins our group, and we inform them, okay, Google is wrong, you won't die within 2 years. इतनी खुशी हो जाती है उनको.
I think that itself
You die.
endears them to us. The very first thing, you're not going to die. Hold on, hold on.
Hmm.
Yeah.
Right.
Yeah, so we'll go to the second one. Yeah, so this is also very important. Like, if your doctor is not a PH specialist, हाँ ये सब थोड़ा 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 ले लो, देखते हैं क्या इफेक्ट आता है, which is not at all that we
And
want.
this thoda is एक बीपी मेडिकेशन दे दो, एक ब्लड थिनर दे दो, एक और क्या है,
वो हार्ट
विटामिन दे
रेट
दो,
वाला. हाँ.
एक डायरेटिक दे दो, एक so कुछ भी दे दो, and then
It's a
done. And
cocktail, yeah.
yeah, it's a cocktail that is given by, and unfortunately, it's a cocktail given by some of the leading cardiologists in India. It's very unfortunate.
Hmm.
Um,
This is
yeah.
like, see, all the medicines we take have side effects and mostly affect our GI system. So,
Right.
and the most common features which fail is diarrhea. So it's like, oh my God, PH से डर नहीं लगता, लेकिन diarrhea से कितने बार टॉयलेट जाके आया हूँ.
I think both of us can attest to the fact that we've already done that today too.
Yes, I am sitting after taking a medicine.
Hmm.
Okay. And like PH is an invisible illness, so हम सबको यही बोलते हैं कि जो हम शक्ल से दिखते हैं वो हम है नहीं.
Right.
Right
Right.
now, you wouldn't have guessed that we both have very severe heart and lung conditions
Correct.
sitting
Correct.
right here across the table. Yeah.
Yeah. Yeah.
एंड ये तो भाई हमारा इंडियन कल्चर है. डिसीज हो कुछ भी हो, वी हैव टू बी स्माइलिंग. हाँ जी, कैसे हो जी,
This
हाँ
is
हम सब अच्छे हैं.
especially relevant to the women who are expected to, still smile. Since everything else is invisible, why not smile?
Right. Right.
Yeah, and continue to be pleasant around people.
Hmm.
Yeah.
Hmm. Okay. Good. Thank you,
Yeah,
Sheetal.
so
Sorry. Go ahead, Prachita.
yeah, that's like these are like so many factors which keep us going. And humor is very, very essential, which I've, I've liked this. Shalaka and Balaji have introduced me to this memes thing. I was never even known to that thing. for us, like laughter was okay. What comedy movies and everything which we see,
Right.
just in one page also there can be so much humor.
Correct,
This is
correct.
good. Yeah.
Right.
It's a coping mechanism.
Hmm. Right. Yeah. And I think initially as well as you highlighted, right, it's also the support of your family and friends,
Oh, yeah.
and that is in so many different ways, right? Because you're dealing with it on a day-to-day basis. They are dealing with it on a day-to-day basis. So that plays a huge role as well. Um, so I think we are coming to the end. So just like to kind of start by wrapping up. If you can, which of you will go first in the wrap up? Uh, Shalaka or Pracheta? So Shalaka, what is the effort of patient advocacy that inspired you or you want to know more about, and your closing comments?
Um, in 2020, when we were starting off with pulmonary hypertension in India, a certain Neetu Wadhwa got in touch with me through Facebook. And the very first day we connected, we had a 3 hour long conversation. I don't know how, because both of us were breathless.
Mm,
But that was how my friendship with Neetu Wadhwa of Scleroderma India, the founder of Scleroderma India, started. She passed away a couple of years ago, and we miss her dearly. But she's someone who mentored me and who was my first guide in this space. And she taught me that, you could be lying down in your bed, all breathless too, and with a smartphone, still drive a whole community out of India, within India. So she was definitely my first inspiration. I'm also inspired by, somebody I discovered recently, which was Lung Connect India Foundation, who focus on lung cancer. And I definitely want to know more about the kind of work they do and how they do it, especially because it's pulmonology and oncology related, and I want to know how they do it. I'm inspired by the sickle cell disease organizations who work with tribal communities in India. There's something to the grassroots level work that they do. They and Thalassemics India,
mm,
amazing. There's a lot to learn from both these communities. And finally, somebody I very recently started working in the rare disease space, and I was exposed to this particular gentleman named Manjeet Singh Sodhi of the Lysosomal Storage Disorder Support
right,
Society.
right,
I'm in awe. I'm in complete awe of what they do. The way they work with the state healthcare systems, with the state governments and the healthcare systems, and what they've done legally to get the rare disease policy moving in India at the High Court level, the Supreme Court level. Amazing, tremendous work, and that is something that at the policy level, at the legal frameworks, creating legal frameworks and having that larger impact on the community. This is something that's the community that I want to work with, learn from, and drive better outcomes. But I
right.
would also, towards the end, sorry, just one, because they need a shout out. There is an upcoming community in the congenital heart disease space, Justice for Heart Warriors, the CHD mission, something like that. I'm excited about what they do in the near future. It is something that will impact more than 2 lakh children a year. It will impact my community as well. And
Right.
I'm very excited and hopeful about everything they're planning to do in the coming years.
Thank you. Thank you. Um, Prachita, do you have any words for other aspiring patient advocates and closing comments?
Yeah. Oh, how much time do I have? So from like learning from my experiences, whatever I can tell, I'll quickly try to say them. The first is knowledge about the disease. You have to know the disease in and out.
Mm,
And nowadays with access to so much information, just make sure that you read the correct information, sit with an expert or take appointment and be thorough with the disease. And then another important thing is communication and networking. This helps increasing visibility, opportunities for collaboration, and also in fundraising. And with all the positives, it is also important to know that being a patient leader is a thankless job.
mm,
Do not expect that everybody is going to support you every time. There are going to be haters, there are going to be people who love you, but you do not have to go by their judgment. You have to do your own thing. Okay. And one important thing is be ethically strong, so that develops trust and respect.
Right.
Otherwise, people will start pointing fingers. If you do some collaboration with some pharma company or some doctors, they will see that there's an inside agenda. But no, you
Mm,
have to be strong on your point. And if you are alone not able to do it, then make a team, build a team which has complementing skill sets,
right,
so that you become strong together. And in the end, it would be just like, start small, stay true and honest to yourself. And it's not about doing everything. Just show up every day with honesty, with your heart in whatever you are doing, and learn, grow with them. And that's how we can change what, and we have to be the change that we wish for.
right,
Yeah,
right.
that's all I think. Yeah.
Thank you. Thank you, Prachita. Thank you, Shalaka. I think we are well over time, but it was an important conversation. And I think to me, a few key messages that came through, right? One is, of course, it highlights the role a patient-led community can play. And it's not just, emotional support, which is what sometimes it gets dismissed as, but it's also navigational support and access to the right care pathways, especially in a country where PH resources are extremely restricted and, concentrated in a few urban centers, right? So there is the role of uh, access to better quality care, as well as, I think, as you guys said, that about helping people make better decisions, right? So that they can improve their quality of life. So I think, more power to Pulmonary Hypertension India. May you kind of continue to grow and extend lives of patients, save them, and improve their quality of life, and improve, drive the treatment guidelines to be more patient-centric as well. So good luck to you. And if anybody who's listened to it has any questions, wants to reach out to them, you can reach them through their social media handles or their website, or if you need to, you can reach out to us and ask for a connect, right? So thank you once again, Shalaka and Prachita, for joining us on a Sunday evening
Thank you
Our
and,
so
pleasure and
much.
an
being
honor.
breathless
Yeah,
and
yeah.
bold, breathless and bold as always.
Yes. Yes.
We both love talking, so yeah.